Welcome back to our video series here at Customizedrelief. Again, I'm joined by Dr. Christopher Roberts, and I'm Curtis Beall. We're the two providers here at Customizedrelief, and we're happy to bring our Back 2 series and continue forward with that. Today, we are going to talk specifically about hypothyroid and maybe some ways that are traditionally not talked about, but I think that play a large part into patients feeling better. And so, I think right off the bat, maybe the things that we start with are, what are the typical ways that we test for the thyroid?
Now, it's a good question. The kind of traditional medicine approach to this is to check a TSH level for low thyroid. That's how I was trained even in medical school. I'm sure you were trained the same way. The problem is that only gets to the pituitary gland and the signaling to the thyroid gland to say we need to release more thyroid hormone. What we're interested in is how much thyroid hormone is actually making it into the cell. It's a difficult measure to achieve, but through blood markers you can get a better idea of, again, how much thyroid is actually getting into the cell and having its impact. So what we typically do is we'll do a TSH level. We check a free T4, and free T4 is the inactive form of thyroid. It has 4 iodine molecules in it. We check a free T3 because one of the iodine molecules will have been pulled out, and that's the active form of thyroid. And then we also check a reverse T3, and this is where, again, we get a little sideways with some of the endocrinologists and traditional medicine world, because reverse T3 basically will block the effect or the impact of the free T3 or the active form of thyroid within the cell. And so again, we don't have an ability to measure inside the cell, but what we can do is we can actually measure in the bloodstream, and from that postulate how much of that information is being carried into the cell. We also like to do antibodies. Again, there's a lot of autoimmunity out now, and it's kind of a nice marker too, because we can not only see, do they have antibodies that are destroying their ability to make thyroid hormone, but it also helps us because as we treat them for their autoimmunity, we can use this as a marker to see that we're having some impact as that number comes down.
Exactly right, and we've had a lot of success with that, and there's certain things I'm sure we'll talk about, ways to bring that autoimmunity down. It's not one of those things that you can't correct. So I guess on that note, what are some symptoms? What should people be looking for when you think of hypothyroid? And I know we see this a lot. What are some of the classic symptoms that we see?
No, good question. One of the biggest things that patients will complain about is weight gain. Constipation, dry skin, dry eyes, cold intolerance. So patients will come in and they say, I had a lady the other day who said, I have to wear a blanket everywhere I go. Again, just generalized fatigue in patients. A lot of times too, we don't ask enough about menstrual cycle, because the menstrual cycle for younger ladies will also oftentimes be impacted by low thyroid as well.
And I actually had a patient the other day as well, and hair loss. So we didn't talk about that. That's
true.
A very big one.
Good point.
And then some nuanced things that we see that maybe go often unnoticed. Specifically, I'm thinking thyroid, and I'll kind of maybe have you touch on that. But what about, cholesterol? Not thyroid, but what with cholesterol does the thyroid have to do?
Yeah, that's an excellent question, and honestly, I hate to admit, I think I learned this back in medical school and sort of forgot about it, but it's really important. We spend so much time in this country trying to chase cholesterol and try to lower it, thinking that we're going to lower cardiovascular risk, and we never really get to but maybe why is the cholesterol high? And what's really interesting is that we've learned that if thyroid is optimal, and again, that means optimal T3, not just T4, then T3 will actually upregulate LDL receptors on liver cells. So if you think about a liver cell as being intimately involved with the bloodstream, I can launch particles. They're VLDL particles that I make in the liver cell that carry cholesterol out to the tissues. Well, I want to have an ability to pull cholesterol-rich particles out of the circulation, and LDL particles have almost no triglycerides in them. VLDL is high in triglycerides with some cholesterol. LDL is what VLDLs become as they give up triglycerides. But I want to be able to pull those LDL particles out of circulation that lowers risk for cardiovascular disease. And so, again, it's not that I need to take a statin or ezetimibe or whatever other cholesterol medicine. Probably the first place to look is to look at, do I have low thyroid?
And to that point, and we haven't discussed this yet, and depending on the lab, as we know, the reference ranges can be all over the place. So for a TSH, I think a lot of you have had a TSH drawn. Most of our patients have when they come in. If you're lucky, they may draw a free T4. That's if you're lucky. And you're looking TSH between 0 and 5. And if you're within that range, then what they would tell you is you don't have to worry. But that's not the case from what we see. We tend to see that actually the closer you get to 5, the more symptoms you're going to have. And we kind of look at that 0 to 2.5, 0 to 2 as our range for TSH. But that being said, as we've discussed, TSH doesn't tell us the whole picture. And do you want to maybe talk about some of the other, where we're looking for free T3, kind of where we want that range, reverse T3,
great question.
and how that may be, to your point, the cholesterol and some of these other symptoms?
No, Curtis, you're absolutely right. Again, if you look even in the endocrinology literature, if you have somebody on active therapy with thyroid, you need to be below 2 on a TSH. Honestly, on free T4, you want to be probably about a 1 to a 1.5 or so. I don't worry as much about T4 as I do T3. T3, though, you really would like to have that at about 3.2 to 4.0. And what's interesting is that we think as we age that our levels may drop a little bit. What's really interesting is that for the cardiac muscle cell, it's really important that T3 stay within a relatively narrow range so that the cardiac works at its optimal function. So again, we like about a 3.2 to 4.0. We can go up sometimes in the lower 4 point list, so 4.3, 4.4. I don't really like to get it above 4.5 because then, again, you tend to have some of the other negative effects of having too much. Reverse T3, at least in the lab that we use now, 12 to 14 is the number. So again, if I'm below that, that actually is not necessarily a bad thing. If I'm above that, though, I'm blocking my T3's impact. And so if we have a patient, we've talked about this before, if we have a patient that comes in, let's say they're at a 3.2 with a free T3, so that looks good, but their reverse T3, so it's actually in my labs recently, was like a 27, well then I'm not going to have as much T3 effect because the reverse T3 is blocking my T3 activity.
And I think that gets back to the idea that T4 is that inactive form. It then has to go down into the cell through the transport chain and then convert to T3. And I've heard this said before, and you could correct me if this isn't totally, this is very superficial, but you think of reverse T3 as almost a kind of a bodyguard at the entry into a club. And its basic role is to ensure that the thyroid's regulating. If you're very stressed or certain things are going on within your system, hormones are out of whack, it's kind of a safety valve to say, hey, we don't want to keep converting that T4 to T3. And so it uses it as a storage form and kind of blocks the T4 from converting to T3,
Absolutely.
Entering the cell and doing its job. So you can have a normal TSH, which is going off of your T4, but have symptoms because your free T3 is so low. And if we see a low free T3, more than likely your reverse T3 is going to be really high. And so you are going to have symptoms of hypothyroidism despite what your TSH says. And so those are some of the things that at our practice, I think we do a good job at least of exploring further labs, and patients then have symptoms and aren't told, hey, your TSH is good, find something else. It usually can be the thyroid even if you have a normal TSH.
No, I think you're absolutely correct.
And I guess to that point, you kind of talked about, well, T4, but that's usually the standard treatment. Can you just kind of go into treatment options and standard treatment and what we use now?
The current standard treatment from just about everybody in traditional medicine is levothyroxine or Synthroid. And the problem with levothyroxine is that it is T4. It is the inactive form of thyroid. Now, the advantage of it is that it has a 6-day half-life. So you can take this, you could forget it on the weekend, and you're not going to see a plummet in your level. The problem, though, is back to what you just said, which is really important that our audience understands. If I have stress, and who of us does not have stress, my body is naturally, if cortisol is high, not going to want to convert T4 into T3 because I want to reserve energy. I don't want to be burning fuel while I'm stressed. So I will convert that to reverse T3, and again, that's the indication of that stress. It's not a good way to treat people if you want to try to get that level of T3 to adequate if they have that underlying problem. So what we typically will add to somebody who's on Synthroid is we'll add cytomel or L-theanine, which is active T3. And again, if we think about how we are designed, our thyroid gland, stimulated by TSH, will release 80% as the inactive T4 and 20% as the active T3. Well, again, that's great, but if I need more T3 from the T4, if I add that in, I can really help to bring that number up to a more, again, what we say optimal level would be. Now, you could, instead of doing levothyroxine and cytomel or L-theanine, you could give patients armor thyroid or desiccated thyroid. It actually comes from a pig thyroid gland. Again, it's an 80-20 mix of T4 to T3. They did a study many years ago in the late 90s that looked at the difference between patients on Synthroid and the patients on armor thyroid, and they did a crossover study. So each group got to be on both medicines. 100% of the patients felt better on the armor thyroid as compared to the levothyroxine.
And we're maybe not going to get into this topic today on this video, but to that autoimmune thyroid, back to that, with Hashimoto's being probably the most well-known, can you tell us of any treatment or what you would do if a patient came in and did have elevated, usually of what's called thyroid peroxidase antibody or TPO, kind of treatment options or things to look at?
Yeah, great question. So the first place to start is diet, because food and the gut drive autoimmune conditions. I still remember a meeting that I went to, probably 17, 18 years ago, and a rheumatologist was at the meeting, and he said, all patients who have any form of autoimmunity must be gluten-free. The gluten protein that we in this country have really elevated in the wheat-based products that we have will drive the imbalances in the immune system that cause autoimmunity to develop. And so the best way to help to restore immune balance is to quit sort of turning on the faucet that's creating more of this self-attacking immune reaction. Other things that we've learned, again, that you and I use regularly, naltrexone, low-dose naltrexone is fantastic to treat autoimmunity, has tremendous anti-inflammatory properties and can help with even some of why people will have elevated cortisol. And so you may be treating kind of two problems as you address that. The last one, and this is a newer one that's come out, it's called amlexinox. And this is really interesting. Tremendous molecule that impedes interleukin 6, TNF alpha, interleukin 1 beta, and NF kappa B. Sorry, these are all pro-inflammatory cytokines, but interleukin 6 in particular is what drives the part of the immune system that creates autoimmunity. And so if you have patients where you can maybe do naltrexone and maybe add in some amlexinox too, you can have a massive impact in helping to drop the autoimmune response, and without having to use a lot of the biologics that we have patients come in to see us all the time who are taking.
Right. And I think the last thing maybe that we'll end on is just the emergence of, and I'll kind of let you take this, the bioregulators, and specifically thyroid for the hypothyroid type symptoms. Can you maybe just delve a little bit into that before we close? Yeah,
it's really interesting. There's some literature out of Russia, and again, everybody sort of turns their nose up a little bit when we say that, but that a lot of that literature is actually being repeated in studies done in the States, and they're seeing similar results. But what they've done is that Dr. Cavinson was the sort of the originator of these, was working off of old data from Dr. Pavlov. A lot of people have heard of Pavlov's dog and related to reward training. Well, they were able to discover that they could take from 1-year-old calves thyroid, again, somewhat similar to the pig thyroid that we talked about, but what they do is they work the number of amino acids down to about 2, 3, 4 amino acid peptides. So again, we'll talk about peptides on a later video. Peptides are any proteins that are under 50 amino acids in length. But the beauty of these bioregulator peptides is that at 2, 3, 4 amino acids in length, you can take those with or without food. Your stomach acid won't break those down, or the enzymes won't break those down. You can absorb those easily into your bloodstream. It appears that they will then migrate to the organ in question and help to address appropriate responses. In other words, if I'm low in thyroid, it tends to upregulate production of thyroid from the thyroid hormone. If I'm high, and this is really where it has probably the most benefit, is that if I'm high thyroid, it's really good about turning down production. And so again, there's a lot of study going on in these right now. Again, they're very safe, so there's no harm in doing this. As you know, we will oftentimes say, hey, we may put you on some naltrexone, amlexinox for the autoimmune side. Let's say your numbers are not abnormal at this point, but let's put you on the thyroid bioregulator too, just to see if we can get a nice balance.
Yeah, perfect. Well, yeah, that's a lot of information. Hope you absorbed that. Maybe watched it a few times. You can tell we're pretty passionate about that here, just because we see it firsthand with the patients, and they come in, they're told they're normal, everything's fine, but they don't feel normal. And a lot of times, if you dig into some of these more deeper labs, you can uncover some things that you'd be pretty surprised about. So we appreciate you taking the time to watch this video. We hope to have quite a bit more coming to you very soon. If you have any suggestions on certain videos you'd like to see, just let us know, and we look forward to helping you further and improve your health.